Bismillah ar-Rahman ar-Rahim. Thanks for the introduction. We are going to talk about a very important topic, which is the dysplasia overview and update. And as an introduction, we know that IBD affects at least 0.4% of European and North Americans, with a rising prevalence worldwide, including in areas such as Asian, Pacific, and developing countries. Most population-based studies have demonstrated that 1.2 to 2-fold higher risk of colorectal carcinoma-related mortality among patients with IBD, even in the modern era. Presently, the incidence of colorectal carcinoma in IBD is lower compared with prior decades due to more effective and safer therapies to control inflammation and improved colonoscopic technologies. The goal of surveillance colonoscopy is to detect dysplasia, the precursor of colorectal carcinoma. We know that there are many risk factors which are either patient-specific or disease-specific or inflammatory complications. Among patient-specific risk factors, primary sclerosing cholangitis, personal history of colorectal neoplasm, family history of colorectal carcinoma, smoking, and MADE6. Among the disease-specific factors, age of IBD at onset, disease duration, disease extent, cumulative inflammatory burden, and disease severity, both endoscopic and histologic. Among inflammatory complications like stricture or short tubular colon, also pseudopolyps, which is debatable. Regarding pathogenesis, there is with the long-term inflammation through the interleukins, which are the signals or TNF, affecting molecular changes through mediators, affecting the targets, leading to dysplasia followed by carcinoma. And there are many mechanisms for that, like oxidative damage, chromosomal instability, microsomal satellite instability, and others. Histologic and endoscopic classification. We have histologic classification, either negative or indefinite, low-grade dysplasia or high-grade dysplasia. The category of indefinite for dysplasia has been removed by many guidelines, putting a legitimate but debatable pressure on the pathologist to decide if there is dysplasia or not. There is high degree of variability in interpretation of the grade of dysplasia, especially low grade, differentiation between dysplasia and reactive changes. So this has led to recommendations that histological slides should be reviewed by a second expert gastrointestinal pathologist. And this is actually the case in most of the IBD centers worldwide. So there are maybe IBD pathologists only, and there is more than one, so the slide should be revised by at least 2. Endoscopic classification, it's either visible dysplasia or invisible dysplasia. Among visible dysplasia, we have polypoid, which is lesions protruding from the mucosa into the lumen, more than 2.5 millimeter, as mentioned before, the closed cup of the forceps. Pedunculated, attached to the mucosa by a stalk. Sessile lesion not attached to the mucosa by a stalk. Entire base is contiguous with the mucosa. Non-polypoid, a lesion little than 2.5 millimeter with no protrusion above the mucosa. Superficial elevated, this protrusion, but less than 2.5 from the lumen. Flat, without protrusion, depressed, at least a portion depressed below the level of the mucosa. General description, ulcerated, is presence of ulcers or not, and the borders either distinct or indistinct. Invisible dysplasia identified on random non-targeted biopsy specimen of colon mucosa without a visible lesion. And this actually is the cynic endoscopic classification of superficial colorectal neoplasm, which illustrates what we have mentioned before. Surveillance, patient selection and timing, societal recommendation differ in details, including when to perform initial and subsequent surveillance colonoscopies. There is consensus that patients with primary sclerosing cholangitis should undergo annual surveillance. Otherwise, societies recommend surveillance intervals ranging from every 1 to 5 years based on personal history of dysplasia, active inflammation, family history, anatomic abnormalities such as inflammatory pseudopolyps or foreshortened colon and stricture. And this actually shows the difference between different societies, and each one has its own guidelines. The methods of surveillance is scenic group recommends chrome endoscopy over white light endoscopy when using a standard definition. But the evidence is still conflicting regarding the benefit of chrome endoscopy over high definition white light endoscopy. NPI narrowband imaging has shown comparable results to chemo endoscopy, but in several studies, not yet recommended by scenic and echo guidelines. There are many new techniques like full spectrum endoscopy and confocal laser endomicroscopy. And this actually, the chrome endoscopy will be covered by Professor Ali Farag in details. Role of random biopsies. The benefit of random biopsies in surveillance colonoscopy is another area of controversy and ongoing research. If a clinician comfortable of performing chrome endoscopy, random biopsy are not required. The scenic panelists, however, did not reach a consensus on this issue. According to ECHO guidelines, random biopsies is still recommended if white light endoscopy is used. In special circumstances, as personal history of dysplasia, concomitant primary sclerosing cholangitis, shortened colon, or extensive pseudopolyposis, random biopsy are still recommended regardless of the screening method. Chemoprevention. Although several agents have been evaluated for prevention of colorectal carcinoma in patients with IBD, none have conclusively been shown to decrease the risk of CRC. 5-ASA, ECHO states that 5-ASA may reduce the incidence of colorectal carcinoma and ulcerative colitis and is suggested for all UC patients. Role of other agents as thiopurine and orthodeoxycholic acid in primary sclerosing cholangitis as a prevention is conflicting and not yet recommended. The management, as we mentioned before, that we have polypoid or sessile. The polypoid dysplasia, if this polyps is smaller than 10 millimeters, resected in block, and surveillance colonoscopy may be performed at 1 year interval. But more than 10 millimeter piecemeal removal surveillance colonoscopy should be performed with 1 to 6 months, as well as 12 months after index resection. Most guidelines recommend biopsying the mucosa adjacent to the resection area, assurance of complete There are some, sorry for the noise, yeah. Non-polypoid dysplasia resection can be technically difficult. Management should be by endoscopist with expertise in advanced endoscopic resection techniques, and surveillance colonoscopy within 1 to 6 months, repeat exam in 12 months after the index resection, then annually thereafter. Invisible dysplasia, as we know that invisible dysplasia, this is discovered by random biopsying. As much as 1/3 of dysplasia initially considered to be invisible is actually visible with high definition white light endoscopy and or chrome endoscopy. If dysplasia is identified by random biopsy, presumably invisible, the pathologic diagnosis of dysplasia should first be confirmed by an expert pathologist with particular expertise in IBD. If confirmed, a repeat endoscopy with enhanced detection should be performed by gastroenterologists with adequate expertise in IBD dysplasia surveillance examination. High-grade dysplasia equals colectomy was advocated for the management of invisible high-grade dysplasia based on the historic data suggesting high rates of synchronous or metachronous cancer. However, most of this data from the pre-chemo endoscopy and high-definition white light endoscopy era. After repetition of endoscopy and the revision of the pathology, if non-resectable lesion is present, further management discussed in a multidisciplinary environment. ECHO and the American Society of Gastrointestinal Endoscopy states that High-grade dysplasia without an associated endoscopically visible lesion is an indication for surgery. Low-grade dysplasia, I won't go for in details in that because Professor Tahir Zanati will cover it in details. Now, this cartoon actually will summarize what we have said. If the patient has no dysplasia, so continue individualized surveillance based on current guidelines recommendation with high definition white light and colonoscopy for colorectal neoplasm screening surveillance in a risk patient with chronic IBD. Now, if there is visible dysplasia with a polypoid, either en-bloc resection if it is less than 1 centimeter with negative margins, and repeat surveillance in 12 months. If complete but piecemeal resection or more than 1 centimeter, repeat surveillance in 3 to 6 months. High-grade dysplasia or multifocal low-grade dysplasia, individualized, consider colectomy. Non-polypoid en-bloc resection, 1 centimeter with negative margins, repeat surveillance 3 to 6 months. Complete but piecemeal resection, 1 centimeter high-grade dysplasia or multifocal, individualized but consider colectomy. Invisible dysplasia, referral to IBD specialist for repeat exam with chrome endoscopy. Individualized low-grade dysplasia based on visible dysplasia scheme. High-grade dysplasia, consider colectomy. And thank you very much. Hello?
Thank you, Professor Baha. Thank you, Professor Baha, for this illustrative overview. Actually, anyone of the chairperson with me, ولا I am alone, ولا؟
البركة فيكي بقى.
حضرتك الكبيرة بتاعتنا يا دكتورة فاطمة.
ربنا يخليك.
معاكي حد يا دكتورة فاطمة.
طيب احنا السكند سبيكر طبعا بروفيسور علي فرج، بروفيسور اوف جاستروانترولوجي كايرو يونيفرسيتي، one of the eminent gastroenterology، يعني مش عايز تقديم يعني. اتفضل يا دكتور علي.
دكتورة فاطمة ازي حضرتك؟
الله يسلمك يا فندم.
الصوت واصل كويس؟
اتفضل.
طيب انا بس هوصل مسج النهارده. What's chromoendoscopy and what's the role of chromoendoscopy in patients with IBD. احنا عندنا مشكله. المشكله ايه؟ المشكله ان العيانين عندهم ulcerative colitis كلنا عارفين انهم at increased risk of colorectal cancer. وبالتالي اغلب الديسبليزيا او اغلب الكانسرز بيبدا كديسبليزيا. وبالتالي لازم نعمل سيرفيلانس كولونوسكوبي عشان نديتكت الكولوريكتال كانسر early and then we proceed. انما عندنا مشكله، مين يقول ان واحد زي ده عنده في اريا اوف ديسبليزيا؟ مفيش. انما لو استخدمنا وسيله ثانيه زي الكرومو اندوسكوبي نقدر نشوف ان فعلا في اريا اوف ديسبليزيا. واضح ان اللي بنشوفه هنا مش اللي بنشوفه كالعاده في العيانين اللي عندهم بوليبس. الامريكان سوسايتي اوف جاستروانترولوجي اسوسيشن قالت ان لازم كل واحد نعمل له سكريننج ناخد منه اتليست 32 راندوم بايوبسيز يصل الى 60 سامبلز. والكلام ده كان 2010. انما الكلام ده اتعمل لما كنا بنستخدم النظام ده اللي مش عارف كام من الموجودين استعمله. انا استعملته الفايبر اوبتيك اللي كان فيه ريزوليوشن قليل جدا. انما الدنيا اتغيرت وبقى فيه ريزوليوشن اعلى. لو انا استخدمت الرادنا بايوبسي انا بشوف 0.1% of the surface mucosa، قليل جدا، جايز التيومر في حته ثانيه. مش بس كده، انا عندي عشان اشوف واحده ديسبليزيا اخد 1000 عينه. مش بس كده، estimated ان only 9% of the patients are diagnosed والاغلب 90% are not diagnosed. دلوقتي اتغيرت المناظير من ستاندرد فايبر اوبتيك الى هاي ريزوليوشن. شوفوا الدنيا اتغيرت ازاي. فيجب مع وجود شيء كهذا ان احنا نغير الكونسبت بتاعنا. الريزوليوشن العالي بيخلي البريسيشن والديتيلز واضحه اكتر. الكرومو اندوسكوب يضيف اكتر كمان، يوريني اي irregularity في الميوكوزا. يعني مثلا this flat area here when you spray endocarmine you can see it very clearly, the borders of a tumor. Now the invisible is being visible, and the studies have shown that almost 90% of patients with dysplasia are visible. Only 10% of the patients you cannot see the dysplasia. The majority of dysplasia is actually visible with the new techniques. اجتمعت مجموعة في 2015 عملوا surveillance of colorectal endoscopic neoplasia detection اللي هو السينك، وحطوا جايد لاينز ليهم. خدوا بالكم الجايد لاينز دي سنة 2015 واحنا دلوقتي 2020، يعني اللي هقوله دلوقتي قد يتغير في المستقبل القريب. جاوبوا على سؤالين، ايه البيست ميثود تو ديتكت وهاو تو مانج. انا ماليش دعوه بالثانيه دي، هتكلم بس هاو تو ديتكت. اول ريكومنديشن قالوا لو هاي ديفينيشن يبقى الاحسن حاجه الهاي ديفينيشن احسن من الستاندرد. قالوا كمان لو بيستخدم ستاندرد استخدم معاه كرومو اندوسكوبي. طب لو بتستخدم هاي ديفينيشن برضه استخدم كرومو اندوسكوبي. يبقى دلوقتي كله كرومو اندوسكوبي كله هاي ديفينيشن لو عندك فرصه. انا هجاوب على سؤالين، ازاي نعمل كرومو اندوسكوبي وازاي او ايه اللي هتلاقيه في الكرومو اندوسكوبي. ازاي تعمل؟ اول حاجه تعملها تحضر العيان كويس. And there is no any reason that you have poorly prepared patients and the highest scope. مش هتشوف حاجه. لازم العيان بتحضر كويس، وانت بتشتغل you suck every area of fluid, you clear every part of the stool. اقدر اعمله بطريقتين. الطريقه الاولانيه ان انا احقن بسبراينج كاثيتر على الوول، ادخل لغايه السيكم وبعدين ابتدي احقن this spraying catheter segment by segment. ابدا في الاول في الاسندنج كولون and then I'll go by way. او ممكن اعمل حاجه ثانيه، احط الانديوكارمين بتاعي او الميثيلين بلو جوه البامب اللي انا بعمل بيها irrigation. اغلبنا دلوقتي بيستخدم اللي هي الووتر بامب دي، اقدر احط فيها المحلول بتاعي واقدر اعمل irrigation بنفس الطريقه اللي عملت بيها بالكاثيتر. زي مثلا ادي عيان اهو في حاجه هنا بس مش واضحه كويس. لما نحقن بقى هنشوف هيبقى شكلها ايه. البوردرز بقت ان في اريا اوف اريثيما، يبقى هذه الاريا I have to deal with it. That's how we do chromoendoscopy. طب what about virtual chromoendoscopy؟ يعني ايه virtual؟ اللي هو الديجيتال، اللي هو ال NBI وال BLI والحاجات اللي شبيهه ليه. برضه نفس المجموعه بتاعت السينك دي اتكلمت على الموضوع ده. قالت لك النارو باند ايمجنج ما هو سجستد في الوقت الحالي. طب ليه يا اخوانا ده كويس؟ قال لك لان مفيش ايفيدنس من الاستاديز عليه خالص. مهما انت بصيت ولقيت وحسيت انه كويس، مفيش ايفيدنس من الاستاديز عليه، وبالتالي از نوت ريكومندد از سكريننج ميثود. اللي ريكومندد ايه؟ الهاي ريزوليوشن وفي نفس الوقت الكرومو اندوسكوبي. طيب لو انا عندي هاي ديفينيشن اقدر استخدم معاه نارو باند؟ نفس القصه برضه ما ينفعش. طب الحاجه الثالثه لو انا عندي ايمج انهانسمنت. يعني ايه ايمج انهانسمنت؟ في بعض الاحيان مثلا كنا بنستخدم او كنا نسمع على الفلورو، نستخدم على اللي هي الماده وتشوف اذا كان في فلوريسنس ولا لا، برضه دي ما فيش ايفيدنس عليه. طيب الكونفوكال برضه الكونفوكال ما فيش ايفيدنس عليه. فكل هذه الاشياء ما هياش محطوطه في الجايد لاينز دلوقتي. What's the take home message؟ بسيطه جدا. The next time you do surveillance for colorectal cancer in patients with IBD please use high definition scope وكرومو اندوسكوبي. طب ما عنديش، ممكن تبعت العين في مكان تاني. هل ممكن استخدم الستاندرد سكوب؟ هتبقى ظلمت العين بتاعك، بس لو استخدمته استخدم معاه كرومو اندوسكوبي. شكرا ليك.
Thank you, Professor Ali. Very concise and very precise presentation في الحقيقة.
شكرا
إحنا-
شكرا.
اخر توك عندنا بروفيسور طاهر الزناتي، طبعا غني عن التعريف وختامها مسك ان شاء الله. اتفضل يا دكتور طاهر.
دكتورة فاطمة، السيادة سعيد بوجودكم معايا في المحاضرة الجميلة دي، إن شاء الله تعجبكم. بشكر طبعا الأورجنايزنج كوميتي على دعوتي. أنا هتكلم النهاردة على low grade dysplasia in IBD. What to do if you find a lesion like that? Sorry, معلش. الكمبيوتر كان معايا. I'll go to a small introduction. We know that endoscopic surveillance for dysplasia and colorectal cancer is recommended in IBD patients. A population-based study كانت على 96,000 IBD patients وجدت ان overall risk for colorectal cancer was 1.29 cases per 1,000 persons per year. In IBD, usually colorectal cancer occurs in a younger age, 40 to 50 years, compared to cancer colon in normal persons, usually above 60 years. Colorectal cancer in males, in IBD patients, is more than males. Crohn's disease, if it is involving the colon, he has the same risk for colorectal cancer as ulcerative colitis. If primary sclerosing cholangitis is associated with ulcerative colitis, this will increase the risk for colorectal cancer and usually affect the right colon. Dysplasia, this is the problem. Dysplastic epithelium is one of the most important biomarkers for malignancy. So it is the rationale for surveillance for IBD associated colorectal cancer. Usually we start surveillance after 8 years of the onset of the disease. And also, if you do surveillance, take biopsies to assess mucosal healing also and the extent of disease activity. If you find a low-grade dysplasia, what to do? You have one of two options. The first option, endoscopic management, followed by continued intensive surveillance program. Or the second option is to refer your patient for surgical treatment. Your decision, usually, which method depends on many factors. The first one is the age and sex of the patient. The second is comorbidity, if there is associated comorbidity in your patients. The duration and the extent of colitis and the degree of disease activity. But the most important factor is the type. This study was published in Journal of Crohn's and Colitis in 2019, July. They looked for the risk of progression of low-grade dysplasia to advanced neoplasia in inflammatory bowel disease, and they found or concluded that accumulative dysplasia was 2% after 15 years of disease, and the age older than 50 years was a risk factor also to progress to low-grade dysplasia detection, and also male sex and follow-up by a tertiary IBD referral centers. All these are identified as risk factors for advanced neoplasia progression. So, further for the need to perform surveillance endoscopies with short intervals in IBD patients diagnosed with low-grade dysplasia. The type of the lesion. There was an old classification, but it is now obsolete. Either raised adenoma-like associated lesion or mass, or a flat lesion. This was abandoned, and now we use the most of the societies agree for the use of Paris classification, which is a simple. It is either polypoidal or non-polypoidal lesion. If polypoidal, it must be more than 2.5 millimeters above the level of the mucosa. It is either pedunculated or sessile. And non-polypoidal lesion, it is usually less than 2.5 millimeters. If it is protruding above the mucosa, non-polypoidal, it is either slightly elevated or flat or depressed. Simply like that, polypoidal dysplasia, sessile, more than 2.5 millimeter above the mucosa or pedunculated. Usually, if it is larger than 1 centimeter or less than 1 centimeter, or non-polypoidal, it is elevated, but less than 2.5 millimeter above the mucosa or flat lesion of the breast lesion. If you see this lesion, you must comment also on two important factors: borders of the lesion, distinct or not, features of submucosal invasion, if it is depressed, ulcerated, or failure to lift if you inject saline mucosal. This is the picture of how chromoendoscopy can delineate a lesion. And this is what the old classification, non-polypoidal dysplastic lesion, slightly elevated, less than 2.5 millimeter. How can I know it is 2.5 or more? Usually, this is the size of the cup of the endoscopy biopsy. And this is what we call previously dysplasia-associated lesion or mass, sessile polypoidal lesion. And this is the pseudopolyps, which we see usually during surveillance, and this is due to inflammation and regeneration. But if I have a polypoidal dysplasia, what is the option? We do polypectomy and take biopsies adjacent to the resection site to detect the dysplasia. If no dysplasia, follow up by annual surveillance and do polypectomy. If the lesion is more than 10 millimeter and you removed it by piecemeal resection, and you must do surveillance after 1, 6, and 12 months first, and take biopsies from the resection site. If it is free of dysplasia, you follow up surveillance every 1 year. If there's dysplasia, refer your patient to surgery. If follow-up surveillance finds incomplete resection or confirmed dysplasia, go to total colectomy, of course. If lesion is less than 10 millimeter and you remove the en-bloc resection, surveillance after 1 year. There is data from 6 studies. Our period was 36 to 82 months. The incidence for colorectal cancer was 6% in this group of patients. What about non-polypoidal dysplasia? It is more difficult to remove and needs expert endoscopists in endoscopic mucosal resection or endoscopic surgical dissection. And you see how it is depressed with elevated edges, and I think this is not lifted, and this is also a very large lesion which needs endoscopic surgical dissection expert in this tool. Resect lesion, it's 1, 6, and 12 plus biopsies from resection site, if free from dysplasia for every 1 year surveillance. If, of course, still there is dysplasia, you must refer your patient to surgery. And this is the types of lesion you can face in these cases. What is dysplasia? It is a dysplasia detected by random biopsies. We call it non-targeted. You must discuss with your patient the risks of colorectal cancer because it is high, and it is better for surgery if you will not do chromoendoscopy. It is more can progress to high-grade dysplasia or colorectal cancer, but it is multifocal dysplasia and your chromoendoscopy. But surgery is an option due to the high risk for colorectal cancer in this invisible dysplasia. 50% risk for colorectal 2.5 years, but if 5 years pass, the risk will decrease to 15%, and after 10%. Sometimes you find this inflammatory pseudopolyps. Of course, this is the result of mucosal ulcerations and regeneration in IBD patients. Move these polyps unless they cause symptoms like bleeding. In the colon. Strictures increase the risk for colorectal cancer. If cannot pass by endoscopy for surveillance, proceed for surgery as cancer or dysplasia in these lesions. In a population-based study on 640 patients with Crohn's disease of the colon, patients with strictures. At 5 years, the risk for colorectal cancer was 5.5%, and at 10 years, it was 7.5%. In conclusion, the risk of colorectal cancer in patients with IBD is related to the type, severity, duration, and the anatomic extent of the disease. Chromoendoscopy with targeted biopsies is the ideal method, but surveillance with high definition, white light colonoscopy with targeted and random biopsies is an acceptable alternative. This plastic polyps is removed endoscopically with close surveillance. If follow-up reveals incomplete polyp resection and dysplasia of cancer is confirmed histologically, refer your patient for surgery. Patients with invisible dysplasia on random biopsies only should be referred for high-definition chromoendoscopy at an expert IBD center. If not available, refer your patient for surgery. I think this is a short resume about how to do in low-grade dysplasia lesions, and thank you for your attention. Thank you.
Thank you, Professor Tahir. And now we come to the closing of the last session. I think Professor Amr Fatin was us, or he leave. I don't know.
Thank you very much. I thank everybody share with us this topics all over the day from 5 o'clock till now, and hopefully we still have audience surviving all these hours. So thank you very much, and we'll see you all tomorrow at 4 o'clock, and enjoy your evening. Thank you very much, everybody.
Thank you, Professor.
Thank you. شكرا.
Thank you.
السلام عليكم.
عليكم السلام.
the challenges in manufacturing biologics. A key objective in medicine is to improve patients' health while ensuring their safety. One breakthrough that has revolutionized medicine and helped meet this objective is the development of a newer type of drugs called biologics. More than 200 biologics have benefited millions of patients worldwide. Biologics are very complex molecules. Because of this, each step in their manufacturing requires rigorous quality control and testing to ensure their efficacy and safety. Prior to the development of biologics, most drugs were composed of small molecules, which are developed in laboratories by using chemical building blocks that are bound together in discrete chemical steps. There could be multiple methods to manufacture them, allowing the drugs to be duplicated and sold by multiple companies when patents expire. Small molecule drugs include most drugs taken orally, in addition to some given by injection. In contrast, biologics are usually proteins, can be up to 1,000 times as large as small molecule drugs, and are given by injection or infusion. Because of their complexity, biologics must be manufactured in living cells. Since their introduction approximately 30 years ago, biologics have helped more than 325 million patients worldwide. Manufacturing a safe and effective biologic medicine requires tremendous effort and vigilance. Every step is critical. It is this rigorous commitment to quality that helps ensure that each dose is both effective and safe for patients.